Welcome to This Explainer. Today, we're zooming in on a notoriously tricky medical topic and turning it into the ultimate study guide. Amoebic liver abscess. Exam ready, 10 marks. If you've ever felt completely overwhelmed by the sheer volume of infectious disease pathology, well, don't worry. We're going to break down this source material together to guarantee you maximize your points on test day.
So how exactly do you snag a perfect 10 out of 10 on an amoebic liver abscess exam question? Well, you need structure. You can't just brain dump facts onto a page and hope for the best. We're going to approach this topic exactly how a medical examiner grades your paper. They're looking for specific clinical buzzwords, a logical understanding of pathogenesis, and of course, a safe, comprehensive management plan. All right, here's our blueprint for today. We've got 1. Parasite pathogenesis and invasion. 2. Classic clinical features. 3. High-yield investigations. 4. Medical and surgical management. And 5. Complications and differentials. Let's get right into it.
First up, Section 1. Parasite pathogenesis and invasion. The actual sequence of events here is pretty fascinating. It all kicks off in the bowel, where the amoebic trophozoites emerge from their vegetative cysts. And from there, they don't just wander aimlessly. They hitch a ride specifically through the portal venous system. This portal venual highway takes them directly to the liver, most commonly the right hepatic lobe. Once they arrive, they begin rapidly multiplying and destroying the liver parenchyma. They're literally melting the tissue away to form an abscess.
Okay, as this process unfolds, we hit what is arguably the most famous visual in parasitology. If you want to lock in those pathology points, you absolutely have to drop these examiner favorite buzzwords. Because the parasite destroys the liver tissue rather than inciting a traditional bacterial response, the liquid contents aren't true pus. At first, it's this pinkish color, but as the necrotic tissue and blood break down, it changes to a thick, chocolate-brown fluid that classically resembles anchovy sauce. Seriously, write that down. Anchovy sauce is money in the bank on exam day.
Moving right along to Section 2, Classic Clinical Features.
You really need to know how to spot this patient in a clinical vignette. You've got to list these classic symptoms. They're typically going to have a swinging temperature and profound sweating. Now, because the abscess is usually in the right lobe, it stretches the liver capsule and irritates the diaphragm, which gives you that classic referred pain straight to the right shoulder. You're also going to find an enlarged tender liver, which we call hepatomegaly. But hey, don't forget their history. Keep in mind they might have a background of amoebic dysentery. That means they could report a history of alternating offensive diarrhea and constipation, sometimes even with blood or mucus in the stool.
All right, Section 3. High-yield investigations. I want you to write this massive statistic down right now. Greater than 95%. Serum antibodies are detectable by immunofluorescence in over 95% of patients with hepatic amoebiasis. This is your absolute most reliable systemic marker. You think, while intestinal amoebiasis might not always trigger a massive antibody response, once that parasite actually invades the liver, the immune system screams, making serology incredibly sensitive.
Now, if the test question points you towards scoping the bowel to find the source, you've got to mention looking for the classic flask-shaped ulcers on sigmoidoscopy. Furthermore, when examining the stool or exudate under the microscope, you're looking for motile trophozoites that are actively engulfing red blood cells. And here's a massive pro tip that examiners go crazy for. You must examine the sample immediately. Why? Because trophozoite motility decreases super rapidly as the stool preparation cools down.
When it comes to imaging, an ultrasonic scan or a CT scan with contrast is totally key here. You'll notice a distinct, dark, multilocular, low-density collection right there in the liver parenchyma. Getting this imaging confirms your diagnosis, shows you the exact size and location, which again is usually the right lobe, and is absolutely vital for guiding potential percutaneous aspiration if things get complicated.
Next up, Section 4, Medical and Surgical Management. We're in the final stretch here, but seriously, pay close attention right now. This management phase contains a massive trap where most students completely lose their points. You must explicitly state that this is a two-part cure. So many students just scribble down metronidazole and move on. Look, metronidazole or long-acting nitromidazoles like tinidazole are fantastic. They'll target and clear the active tissue infection in the liver. But if you stop there, the patient is going to relapse. You absolutely must follow it up with a luminal agent, like paramycin or diloxanide furoate, usually for about 10 days. This second step eliminates the surviving vegetative cysts that are still hiding out in the bowel lumen. 2 parts, tissue, then lumen.
And, when it comes to surgery, Don't be too eager to operate. Make sure you clarify to the examiner that routine surgical drainage is actually quite rare for amoebic abscesses. They respond incredibly well to medical therapy. Aspiration is strictly reserved for specific criteria. If the abscess is very large, if it's located in a precarious spot where it threatens to burst, or if there's a failure to respond promptly to the chemotherapy we just went over.
Finally, Section 5, Complications and Differentials.
Let's map out these honestly terrifying complications to really demonstrate a wider clinical understanding to your examiner. Because the liver sits right up against the diaphragm, a large right lobe abscess can actually penetrate the diaphragm, rupture directly into the lung, and create a hepatobronchial fistula. The patient will literally cough up that anchovy sauce pus. It's wild. It can also rupture into the pleural or peritoneal cavities. But the most fatal complication you need to mention is if the abscess happens to be in the left lobe, it can rupture directly into the pericardial sac, causing sudden cardiac tamponade.
To round out your answer, briefly show off by contrasting the amoebic abscess with a pyogenic liver abscess. While amoebic is caused by a single parasite, usually in patients with a travel history, a pyogenic abscess is generally an infection in older patients stemming from a biliary tract disease, like cholangitis, or colonic pathology. Pyogenic abscesses are typically polymicrobial, involving bugs like E. coli, Klebsiella, and anaerobes. Showing you know this difference proves you're thinking like a real clinician.
So, let's bring it all together. By mentally contrasting the anchovy sauce pathology of an amoebic infection against the bacterial soup of a pyogenic one, and by remembering that critical two-part treatment of tissue followed by luminal clearance, you haven't just memorized facts. You've built a structured, examiner-friendly framework, and you've absolutely secured your 10 marks. But it does leave you wondering, as global travel increases and climate zones shift, how long until rare parasitic presentations like this become common clinical encounters in your very own local emergency room?